We'd love to open up things to questions, and I think that thank you. That was a fantastic talk, and I think it certainly sort of is overarching with respect to all that we've been talking about here. Yves, I know you're very active in the field. And I guess so. How does this change, or how would this potentially change the way that you think about surgical aortic valve replacement, TAVR replacement, if the longevity issues were less of a concern?
I'd probably try to focus on investing in whatever company Cindy's going to because we'll all be out of a job. No, I mean, I think this is, this is exciting. I mean, this is more than exciting. The results that Cindy and her lab have demonstrated are very promising. We have seen, industry work on different variety and versions of anti-calcific therapies, and every valve has some version of that. What we haven't seen is the kind of results that Cindy has demonstrated. The next step, once this is proven, would be to then take the next step, coat valves, and potentially get to a druggable target. Boy, oh boy. I mean, as I said, there'll be some empty valve clinics once that happens.
And Cindy, so how far off? How long do we have to wait for that?
Well, it takes a village. It also takes a lot of money. So we're trying to do both right now and get funding to really push forward with this system to screen drugs. So, I mean, it really depends. I mean, we're working hard towards it, though.
Yeah, fantastic. So Amber, you talked to us about the variety of valves that we have. What is, the process is clearly nuanced. We've heard that from a number of different talks. So how do you choose, what's driving your choice of valve? And especially in some areas, some of the valves we have, it's a little bit of a data-free zone. And is there more data coming out in some of the newer valves that might help us in the decision making?
Yeah, absolutely. I think it takes, certainly an extensive conversation with the patient, understanding their age, their risk factors, the presence of coronary artery disease, what is their predicted longevity, just to better understand the necessary longevity of a valve, and their risk factors, as well as how high risk they are kind of the factors that I think we take into account. I think looking at their anatomy and their CT scan, evaluating everybody's CT scan on your own is incredibly important. I think it really brings to light a lot of things that we don't necessarily otherwise realize, like heavy calcification, areas of calcification, the aortic root angulation, and I think those are all factors that we take into account. I think that as we continue to get more data on the Abbott Navitor valve, as well as long-term data on the other valves, I think we'll have a little bit more light shed on the long-term durability, which I think is really going to be one of the biggest factors for us moving forward.
Great, excellent. That brings me to you, Dustin. So you said we're not there yet. So how do you manage your patients? They're on the internet. They're seeing all of these tweets. They come to you and they really don't want to end up with a surgical valve. They want something that's going to be, as you've nicely highlighted, go in, go out, you're golfing the next day. How do you manage those patients? How do you work with them and talk them through that whole process?
Yeah, so this is a huge challenge. Everybody comes in with a preconceived notion, and the preconceived notion and preference is not for sternotomy. So it's obviously a big challenge for us. When I'm speaking with them, I try to talk about not just what we're doing now, but what are we going to have the option to do in the future. And I speak with them a bit about their CT scan result. Am I putting in a large valve? Am I not able to put in a large valve? Is it going to be a small transcatheter prosthesis? What is the likelihood based on anatomy, sinuses, valsalva, diameters, coronary heights that we'll be able to do this a second time? And then I do clearly bring up the explant TAVR registry. I think we have to at this point, that we go from a low-risk patient who has a mortality of less than 1% with their sternotomy, and we convert that into a patient who has a 10% risk of mortality if something goes wrong with their transcatheter valve. That's a scary statistic for anybody who's going to TAVR somebody with a greater than 20-year life expectancy, and I feel like in interest of full disclosure, they need to know that as well. And then the best tool that we have for that is a true collaborative relationship with our surgeons and our cardiologists. You come to the valve clinic for discussion about what your options are. You're not just meeting a cardiologist. You're not just meeting a surgeon. You're going to meet both. And you know, we truly both give our spiel, and we find that it is often the case that I'm pushing for surgery and the surgeons are pushing for TAVR. So it is often quite a role reversal that we see. But all those factor in, and I think the more information we can give the patient, the better.
Great. Yeah, thank you. I have a question from online.
Ken, I'll let you repeat it. Can the panel comment on the considerations for patients' status post-CABG who now require aortic valve replacement? And I guess maybe I'll add the consideration of patients who need both CABG and AVR. Or that.
I'm just going to read it through. You just,
Can the panel comment on the considerations for patients' status post-CABG who now require aortic valve replacement?
Callan may be the wrong person to answer, but you should take it.
I don't know if this is working, but you know, obviously post-CABG, another surgery would be sort of higher risk, so you're elevating the risk of another procedure. I think we're kind of leaning more and more towards, you know, TAVR in this patient population. If the initial CABG operation was of good quality and you have, you know, multiple arterial conduits, you don't even need to worry so much about the coronaries that much. So in fact, it makes it somewhat easier as far as that goes. And you know, conversely, if you need CABG, obviously the surgical approach is better, right? Especially if you need an IMA, if you need a proximal LAD disease or left main disease, that's a no-brainer.
great.
Another question from the chat, asking about studies looking at incidence or progression of calcific aortic valve stenosis and dietary intake, comparing potentially different diets or vegan or ketogenic dietary intake populations, and whether TERT or STAT5 is changed on those dietary intakes.
Yeah, so we're the first to actually report TERT and STAT5 interaction, period. So I have not gone back and looked at anything related to dietary consumption and that interaction. I don't believe there is any robust studies on nutritional intake and calcific aortic valve disease progression, but you know, it does have somewhat similar risk factors to coronary artery disease. But I'm just the basic scientist, so it's not involved in TERT and STAT5 that we know of yet.
I think that would involve feeding some knockout mice pizza or steaks.
So Catalin, I mean, the work that you show with respect to treating patients with coronary disease after they've had TAVR is really challenging situation. So how, as we move forward, do we train our interventional cardiologists so that in the middle of the night when they're dealing with a post-TAVR patient, they have increased the likelihood of a successful recanalization of a STEMI patient?
It's an issue of being familiar with the prosthesis and becoming familiar with the environment. And I think, you know, certainly our fellows get exposed to that, and people become more familiar with what this prosthesis look like and what the challenges are. In conferences like this, they certainly help. And it's a relatively simple set of rules that you need to go by in order to achieve successful procedure. The problem is that a lot of this, the physicians that do the TAVR, like ourselves, are not necessarily the physicians that do the STEMIs in the middle of the night in the community. So that's sort of the little gap that we need to bridge. But again, talking more about it and making people understand that this is not really rocket science. It's relatively simple if you follow some simple rules like we were showing. I think it's very achievable.
Great.
And of course, referral to, I mean, if it's an elective procedure that's complicated and someone who had 3 TAVRs, then that perhaps may be worth referring somewhere else.
And Derek, you talked to us about aortic valve repair, and you showed some fantastic Tyrone David data with respect to 20 years out. So I guess one question is that happening? Can other people achieve those results? One. And then secondly, is there any way that we should think about these valves if they do fail with respect to repeat surgery or transcatheter treatments?
So I guess the first thing is you know, I do think that those results are achievable by others. I think that the technique is very well defined. I think, you know, in centers that do see a lot of those patients, I think the results are obviously going to be better. We know with lots of other operations, there's a very clear volume and quality kind of connection. In regards to repeat surgery, it's going to depend a lot on the way that they fail. If they fail with calcium or becoming stenotic, then TAVR may be an option in there. But if they fail without, you know, with aortic regurgitation, and there's not a high calcium burden to hold the valve in there, then those are patients I think are going to go on to either getting a, you know, bioprosthetic reoperative root replacement, or you know, if it's a patient that failed at a young age, then a mechanical root replacement. Yeah.
Great, great. And Tim, you know, you've done a fantastic job at setting up a really multidisciplinary hypertrophic cardiomyopathy program at our institution. Can you tell us, you know, what are the key components to that, and you know, how you've been able to do that?
So I think I think multiple folks have said it's a team effort, and it really starts in the community, where a good communication with PCPs and local cardiologists, educating folks about the concept of hypertrophic cardiomyopathy, how to recognize it, and first and second line therapy, and also really, you know, trying to partner with them in terms of, you know, discussing when is it appropriate to trigger third line therapy or septal reduction therapy. And I think keeping that conversation going over years, because what we now know is that even if you have a diagnosis of HCM, your life expectancy should be normal, and with modern therapy. And I think, you know, preparing for a 5, 10, 20-year discussion is really, you know, key to good patient outcomes.
Yeah. Fantastic. Anything else from online, Josh?
This is from Dr. Andy Kaiser asks, is there a long-term advantage to adding annular stabilization to valve repair?
Yeah, I think if you look at the data that I had presented, you know, from the German group, in 2009 they had started adding annular stabilization to their remodeling procedures. They did see a decrease in aortic regurgitation over time. Again, I think it goes back to kind of the pathology. If it's the initial pathology starts in the root, in lots of patients who have genetic syndrome, Marfan's, things like that, then you're going to have a higher chance of that annulus dilating over time, leading to that mechanism of aortic regurgitation. I think those are the patients that annular stabilization definitely benefit.
Great.
Yeah, I think the Lansac, both the Lansac ring and Hokum Schaefer's data that you showed, Emmanuel Lansac and Hokum Schaefer's probably have the largest experience with the remodeling and stabilization.
And then just for the whole panel, any takers, there's the talk of valve in valve. We've heard a lot of different comments on it, the pros and the cons, and there's it's a very nuanced approach as well, with details with respect to the valves that are possible. Can we talk about that in a little greater detail so our audience has a better feel for, you know, what the limitations might be for that?
I can take that one. I think the challenge that we have when we talk about a transcatheter valve and surgical valve is the same challenge we're going to have with transcatheter valve and transcatheter valve. And the first thing we need to establish is that the surgical bioprosthesis that goes in has to be of adequate size, and that may require a root enlargement in some of these cases. If somebody has a very small root, putting a 19 millimeter surgical bioprosthesis in and telling the patient that day they'll never have to have a sternotomy again because we'll simply put a transcatheter valve inside is just quite frankly incorrect. So I think the first thing to do is know that this is a problem of orifice, and if we put something in that leaves a small orifice behind, layering metal inside of that in the future is not going to be helpful. The second consideration is, you know, we really do need to pay attention to coronary perfusion and coronary heights, and if we're placing a bioprosthesis with the post of that valve that's going to come above the sinotubular junction. If we're using a valve that has externally mounted leaflets, we may need to do a leaflet modification strategy in the future, like a basilica, in order to have that procedure done. And we're running into that a lot with our trifecta volume. And the third component of a prosthesis is if a small prosthesis is going to go in, the ability to modify the sewing ring of that valve and fracture that sewing ring at the time of transcatheter valve replacement inside that to put in a bigger transcatheter prosthesis becomes important. So really the three things we talk about are what is the size of the valve that's going in? Is it modifiable by a bioprosthetic valve modification or a ring fracture? And what is going to be the strategy for the leaflet modification if it comes above the sinotubular junction? So we're externally mounted leaflets seen in the trifecta and in the mitral flow are much higher risk for coronary obstruction for any valve-in-valve procedure, especially when we're dealing with a narrow sinus of Valsalva or a short sinotubular junction. So there's clearly a lot of nuance to it, and that's where I think a center with very involved cardiologists and very involved surgeons, not only at the time of the initial implant, but at the time of the need for reintervention is very helpful.
Great. And maybe if just a quick last comment on vascular access, approach to TAVR. How do you make those decisions? We're talking about an older population with concomitant vascular disease, and sometimes the standard approach is not available to you. How do you manage that?
I think we've gotten, and this is kudos to technology and the engineers who designed these delivery systems. I think majority of the patients are treated by transfemoral approach. Again, I think we take a lot of pride in not having a hammer nail approach, which is, you have a patient that clearly needs a transcatheter valve, and transfemoral access is not appropriate or adequate. We have a very low threshold to using carotid or subclavian access. Historically, we've used subclavian access, and we've presented on this multiple times and published this, that despite the patients who need alternative access have worse lung disease, worse kidney disease, higher STS-PROM, they still tend to do just as well as TF patients. Take that one step further and move that towards a carotid access. We've noticed that those patients tend to go home the next day just like transfemoral patients because less risk of nerve injury, less mobility issues. So we've really, and really no increase in stroke. And we don't have a large enough sample size to publish that. But again, obviously data from the TVT registry shows that carotid access would be the preferred, secondary access to non-transfemoral. And again, I think, putting 5 different iliac stents in and fracturing and shock waving and trying to go TF and then stenting on the way out or the way in is likely not the approach that we would recommend. I think if you've got a good partnership and understanding and skill set between the interventional cardiologist and the surgeon, the heart team, you can tackle really any of these patients successfully.
Great, outstanding. I'd like to thank all those viewers for the questions that were provided, as well as the panel for your excellent presentations and commentary. And with that, we'll break. And I believe we have a live case that we'll go to.
Great.
Thank you.
Thank you. So this is incredible. A bunch of cardiologists and surgeons on time. This never happens. So thank you again for all your thoughts and comments. So we will move on to the panel now. So this is going to be interesting. This is a case that we had recorded probably about a couple weeks ago. Just going to hand you this. So what we'll do is, we have kind of the meat of the case here that talks about, what we did. This is a transcatheter aortic valve case. Dustin has some case data to present on, and we'd love to have another panelist here. Who am I missing? All right, great. Conrad, do you have a few minutes to join? Sure. All right, perfect. Thank you. All right, let's get started.